Soumya PP. She'll be talking about a small pupil phacoemulsification beginner's tip. And Dr. Mohan Rajan, you wanted to go early, so you could be ready for the next talk on the other side.
Good afternoon, everyone. Thank you, AIOS, from my part. I'm going to deal with small pupil phacoemulsification, a beginner's tip. Myself, Dr. Soumya, I'm come from Kerala. Why small pupil is a problem? A normal pupil of more than 6 millimeters is ideal for phacoemulsification. A pupillary size of less than 4 millimeters makes it surgically risky. How is it risky? It is incomplete view of the anterior capsule, which makes it difficult capsulorhexis, a limited space for phaco probe and even a second instrument, higher chances of iris trauma, posterior capsular rupture, vitreous loss. It may be associated with pseudoexfoliation, diabetes, uveitis, floppy iris. So, going to the surgical part, before even going to the surgical part, preoperative preparation is also very important. Identify the high-risk patients, PXF, uveitis, diabetes, alpha-UCAS blockers, and maximize the dilatation. That is topical mydriatics and topical NSAIDs could be used for this. And at most importance is counsel the patient about the longer surgical time and possibility of the iris manipulations. Coming to the intraoperative management part, there is pharmacological methods, mechanical method, as well as phacoemulsification technique modifications. The pharmacological methods include intracameral mydriatics, like phenylephrine or epinephrine injected into the AC. Phenylephrine or ketorolac combination can also be used. See a small pupil while injecting. You can see dilatation of the pupil. Coming to the mechanical method, first one is the viscomydriasis. Inject a cohesive OVD like Helione or Provisc into the pupillary margin, pushes the iris backwards and enlarges the pupil. It is a simple but temporary, often combined with other techniques. Coming to the next part, that is iris stretching. Two instruments can be used for the stretching of the pupillary iris radially. It provides immediate enlargement but causes a permanent sphincter tear, irregular pupil, or photophobia and glare. See, two instruments can be used. It may be ideal that we can do in one part and you can put a viscoelastic material. Coming to the sphincterotomies, small radial incision on the pupillary margin with micro scissors can also be used. It is effective in atonic or rigid pupils like in chronic uveitis or older eyes, and permanent cosmetic defect is the drawback. So the another part is iris hooks. A 4 to 6 iris hooks placed through the limbal paracentesis, and it is adjustable. It can make a square or diamond shaped pupil. It is a very stable, useful in IFSS and pseudo exfoliation. See, it's a square shape. And we can even use pupillary expansion devices, Malugian ring or B-hex, and it's the gold standard for IFS and very small pupil. Phacoemulsification technique modifications can also be used, like staining of the capsules. It is utmost importance. Use a tryptophan blue dye for capsule visualization. And you have to make a difference between a rigid pupil and a floppy pupil, and before you go into the operative measures, that is rigid pupil, a pupil that does not dilate well preoperatively or fails to enlarge intraoperatively despite maximal pharmacological mydriasis. And the causes are pseudoexfoliation, chronic meiotic use, diabetes, etc. And challenges in the phaco is poor red reflex and visibility and the increased risk of iris trauma as well. There is a high chance of posterior capsule rupture and incomplete cortex removal. So management in this part is that we can use intracameral mydriatics, viscomydriatic, stretch pupilloplasty, sphincterotomies, and mechanical expanders. Coming to the floppy iris, intraoperative floppy iris syndrome especially is seen in tamsulosin usage and other alpha blockers users. So the key features of IFIS is that billowing of the iris trauma during irrigation itself and iris prolapse through the incision, progressive intraoperative meiosis as well. So these are the causes, as I said earlier, and the challenges in phaco even is iris trauma, hyphema, increased capsular rupture, and the management includes preoperatively you can use 1% atropine, intracameral phenylephrine or phenylephrine ketorolac combinations, high viscosity cohesive OVDs, reduced irrigation, aspiration flow rate, and the bottle height. This is at most importance. And coming to the mechanical devices, iris hooks, Malugian rings, and for the severe cases. Coming to the nuclear management, you can avoid sculpting. This is a risk for hitting the iris and prefer chopping techniques. Use phaco settings with lower flow rate and vacuum to minimize the iris flutter. This is a small pupil phacoemulsification without a pupillary expander. You can even try it on a later stage. I'm showing this because a few steps are there, like dye is injected and visco is put in a careful manner. And the rhexis is done. Usually I do it under cover. And careful hydrodissection is given. Because the posterior capsule will be very thin in these cases. Adequate visco and nucleus rotation. And you can see the few cortex, that is loose cortex, is removed. And I'm going in for a direct vertical chop. And in each step, I'm using visco in between. And after all the nucleus pieces are being taken out, IOL is put inside the bag. The cortical aspiration is also to be taken care of, and IOL implantation ensure haptics well inside the capsular bag, which reduces the risk of capsular rupture. And special situation, you can use CTR in pseudoexfoliation, and uveitis cases, you can use a sphincterotomy or mechanical expansion. Postoperative consideration also is important because there is increased chance of fibrinous exudates and IOP rises. Intensive topical steroids and NSAIDs could be used, and careful follow-up for
Madam,
the CMEs.
Please summarize.
This is the summarization: phacoemulsification, small people, preoperative, intraoperative, and postoperative management. No financial interest. Thank you.
Thank you, Dr. Soumya. I think